One and
So hello and welcome everybody to this evening's HTD Centenary Seminar on Leishmaniasis, and we've got an hour of action-packed presentations for you, starting off with Adam Gray, who's our ID registrar, who helped us found this Leishmaniasis MDT less than a year ago now, and he's going to take us through some of our numbers and some interesting facts. And then we've got two tricky cases. Firstly, one presented by Christina Fernandez and colleagues in North Manchester General, a tricky case of visceral leishmaniasis. And then Steve Walker, consultant dermatologist, is going to talk about American cutaneous leishmaniasis 3 ways. So Adam, over to you.
Thanks, Anna. So yeah, no, really interesting. Thanks for letting me come and talk here. So we set up this Leishmaniasis MDT earlier this year, and it's been running for about 8 months now. And when we were starting it, we tried to come up with really what was the purpose, and we said we wanted to make an MDT there could be a single unified point of referral, and also provide a governance structure. You know, a lot of these clinical decisions have a poor evidence base and really require a lot of expertise, and so offer the service to the whole of the UK for any VL, PKDL, mucosal leishmaniasis, or any complex cutaneous leishmaniasis. And the idea is that we are trying to coordinate with the referrers to provide some sort of collaborative service, recognizing that sometimes people just need a bit of advice. Sometimes it's really helpful to have patients reviewed at the Hospital of Tropical Diseases, but also that the whole process is sort of educational for everyone involved. So anyone can refer to us, and that's the email address there for those that are interested. And so we have a MDT once a month. And we've been doing that for the last 7 or 8 months now. We can also do it ad hoc if there are urgent things, which occasionally there are, and we will reply to email relatively quickly. So in the team, we've got people from parasitology, that's the outgoing Professor Chiodini, and the incoming Laura Nabarro, Anna Checkley, who's one of the consultants in infectious diseases here at UCLH. Jonathan Joseph is an ENT consultant with a particular interest in mucosal leash, and Steve Walker, who is our tropical dermatologist. And then there's been a couple of us registrars involved. For the time being, I'm coordinating the MDT. Yeah. So we've discussed 18 separate patients over the last 7 months. Some of these people were well known to the leash team, I guess, here at HTD for many years. And part of the reason for the MDT was to say, well, all these consultants are already providing advice through whatever means, but to try and bring that together, make it cohesive and unanimous. And so just a couple of bar charts just to show that, you know, the numbers are increasing, and we're rediscussing a reasonable number of people because obviously, you know, as things progress, response to treatment. And there's a reasonable amount of people who we just discussed the once, but clearly there are a few that are very, very complex, and we'll discuss some of those later, who require numerous discussions over a period of time as things change and our decision making may change. We've had referrals from most of England, a lot of which so from around London, but also we've had a referral from Poland that came through the London School, and a referral not from Morocco but from Gibraltar, which of course is sort of part of the NHS system as an overseas territory, and the sort of things that are presenting from different places are obviously slightly different, and it depends a little bit on what their local ID services might be like. But proud to be offering an international service. And then I guess this is just to give a little flavour of the kind of cases that we're discussing and how we're trying to work it out as a system. So, for example, in the centre there, these are people who we are only providing advice for, and at no stage these people are going to end up coming to HTD for sort of a clinical review. So, for example, we provided advice for an older lady in the very, very rural Cornwall, cutaneous leishmaniasis, who was being managed by the local ID team there. And that was great. And we gave them some advice on different options they might have. And then there are some people who the UCLH does take on sort of full-term management, I suppose, as it was. So especially those with mucosal leash, they're seen regularly in a joint dermatology ENT clinic by Jonathan and Steve, because it can be a particularly difficult thing to pick up and recognise relapses and so on and so forth. But this is a spectrum, and we recognise that some people will be under long-term follow-up at the HD by their own request or otherwise. Some will see once and some will see never. So there you go. That is a rough summary of how our MDT is shaping up to date, and it'll be really interesting to see how it continues to work over the rest of the year. Thank you very much, and I'll pass you back to Anna.
Fantastic, thank you, Adam. That's a great overview. And if there's any questions about how the MDT runs, how to access it, etc., then both Adam and I would be happy to answer those later. But I think for the meantime, we'll move straight on to Christina Fernandez. And really, that blob over North Manchester General should have been much bigger than, because this one patient, I think, really prompted the formation of the MDT, didn't it, Peter, as we convened informal MDTs several times and all scratched our heads as we entered this evidence-free zone. So this is a patient who's really very familiar to both the Manchester and the HTD teams. And Christina, look forward to hearing about him. Thank you.
Thanks, Anna. Let me just share my slides. I hope you can see them. Yep. So thanks so much for the opportunity to present this case, and I'm here with Javi Villar, who's the consultant that's been taking care of this gentleman that I'm going to present for the last 5 years. So Matt presented to the ED department here in North Manchester General Hospital in July of 2017, 3 days after landing in Manchester Airport on a plane from Spain. At the time he was 32, he was born in Romania but actually lived in Spain since his late teens. And he came with a discharge summary that had the following diagnoses on them, on it. So in 2006, he was diagnosed with HIV and visceral leishmaniasis. He'd had episodes of disengagement with care. He had bilateral deafness and suprarenal insufficiency. And hopefully what you can see on this slide is that he'd already had extensive treatment for visceral leash in Spain. So he'd had both monotherapy and combination therapy with liposomal amphotericin B alongside miltefosine, and more recently antimonial therapy with sodium stibogluconate. And despite having episodes of disengagement with HIV care, he'd actually been taking his antiretrovirals consistently since about 2015. And in July, when we first met Matt, he presented with weight loss, fever and diarrhea. He was pancytopenic and had significant hepatosplenomegaly. And on arrival to the ED department, he said that he'd been taking miltefosine monotherapy as prophylaxis for about 6 weeks. He had a CT of his abdomen that confirmed hepatosplenomegaly and actually also showed enhancement of the bowel wall, and colonic and bone marrow biopsies confirmed Leishmania infection. And this is a slide of his bone marrow that shows a very pretty hematocrit right there in the centre. So he was treated with liposomal amphotericin B ambisome, but this only provided a partial clinical response, and so he was then given sodium stibogluconate for 28 days, which completely resolved his symptoms, and he actually started to put weight on the ward. But actually he didn't really behave very well when he was on the ward, so he was discharged after a 2-month hospital stay on monthly amphotericin prophylaxis as an outpatient. And then over the next couple of years, Matt has a few relapses of VL. In 2018, he has 2 courses of sodium stibogluconate. The second, unfortunately, provides very little clinical response, so he's then treated with ambisome. And I think at the end of 2018 is when he's first discussed with the Leishmania group at the HTD, and we've really been in constant communication with him ever since. In 2019, he has another 2 courses with of liposomal amphotericin B plus miltefosine, and you can see here that actually the ambisome is given at a higher dose, but after the second course, he develops significant renal tubular acidosis secondary to the ambisome. So this has to be switched to sodium stibogluconate. And it's just worth mentioning that over these 2 years, he does have episodes or periods of time where he stops taking his antiretroviral therapy, but he has relapses of VL both on and off ART. And despite much of the clinical evidence for relapse, it being a worsening pancytopenia, hypoalbuminemia, ascites, constitutional symptoms, I guess this slide is here to say that there's also good evidence for ongoing Leishmania infection, both radiologically and on histology. So as you can see here, there's reports of massive splenomegaly, hepatomegaly, mesenteric lymphadenopathy, portal hypertension, and samples from his bone marrow and his colonic biopsies show a mastocytosis, as you can see on this picture here. And then in early 2020, Matt is actually doing quite well. He's in long-term accommodation for the first time and is fully compliant with his ART and his Leishmania prophylaxis. But unfortunately, in May, his clinical condition starts deteriorating. And despite not requiring hospital admission at this time, it's felt that he's soon going to require treatment for VL once again. And he again is discussed with the Leishmania group at the HTD. He has a Leishmania PCR done in blood, which is positive. And in June, when he eventually requires admission to hospital, he's offered treatment with pentamidine intravenously for 21 days. Whilst on this, he unfortunately develops renal tubular acidosis once again with hyperkalemia and hepatitis, but actually miraculously manages to complete this 21-day course, and a blood PCR is negative, for Leishmania is negative on completion of treatment. And then there's ongoing discussion about what to do or how to best proceed in terms of prophylactic options after this course of pentamidine, because the expectation is that without it, he will no doubt relapse. And so these were the options that were discussed. Sodium stibogluconate, the antimonial, or liposomal amphotericin B, both have failed as treatment options in the past, and ambisome actually cause life-threatening renal tubular acidosis. Miltefosine has failed as monotherapy as prophylaxis and in combination treatments. Promomycin is not recommended by the WHO, and in any case we don't have it in the UK at the time. And pentamidine has worked in his previous relapse, but there's extensive discussion to say, you know, what would we use if he relapses whilst on pentamidine prophylaxis? And so the decision from the MDT is to offer Matt pentamidine prophylaxis with monthly Leishmania PCRs on blood for early detection of relapse. And a clinic letter in October of 2020 states that Matt looks a picture of health and is doing fantastically well. But unfortunately, this is quite short-lived, and by December, he develops a new progressive skin rash, particularly affecting his face. But this is a picture of Matt's back, and it soon becomes apparent that this is secondary to VL. And he has a couple of hospital admissions with a dry cough and breathlessness, and a CT done at the time shows ground glass changes of the bases of his lungs with hilar and subcarinal lymphadenopathy. He's worked up for a future relapse, and the MDT now feel that Matt has developed PKDL, so this is post-Kala-Azar dermal leishmaniasis. And the Leishmania group actually take his case to the WHO team members for an international view of how best to proceed. But unfortunately, by the end of December, Matt is now hypoxic, he's more breathless, and he has a CT which shows that he now has ground glass changes affecting all of his lung fields, and both bone marrow and skin biopsies show that there are mastocytes on histology and are PCR positive for Leishmania. And actually the histological changes on his skin biopsy are felt to be consistent with PKDL. So at the time in December, Matt now has evidence of PKDL on skin biopsy. He has an active pneumonitis of uncertain origin, and his HIV is well controlled, and the MDT feels that he requires treatment for disseminated Leishmania once again with a long enough treatment course to cover PKDL. And sorry, the slides are jumping a little bit, but these are all the previous treatment regimens that have not worked or caused life-threatening side effects in the past. And the MDT decision is to offer him a course of treatment with IV promomycin, which we have now thankfully sourced, and the antimonial meglumine, as sodium cybergluconate is not available in the UK at the time, with the rationale that dual therapy will help protect the IV promomycin, which is the new agent that he's not had before. And the duration will be dictated by until there are no mastocytes seen on splenic biopsy, which is common practice in HIV co-infected individuals in East Africa. So this is a little busy, but if a busy slide, but if I just talk you through it, in February, Matt starts a treatment course of promomycin and meglumine, and actually his breathlessness rapidly improves, and about a month in, it's completely resolved, and his rash somewhat recedes. But whilst on this treatment regimen, he develops arresting tremor, ataxia, vertigo. He's intermittently confused to the point where he loses capacity and requires an IMCA. He has a significant prolongation of his QTC and deterioration in his vision. And these are all felt to be due to cumulative antimonial toxicity, and so this regimen has to be stopped. And the table here at the bottom just shows the splenic aspirate results, and you can see there is a 10-fold drop in the mastocytic burden on his splenic aspirate, but this was actually felt to be less than expected in someone that was promomycin naive. And 10 days after stopping this regimen, he's commenced once again on promomycin, but this time alongside miltefosine. But unfortunately, there's no difference at all in the amastocytic burden on splenic biopsies, and therefore this is felt to be futile and stopped. And just of note, the antimony levels done both in urine and blood in August, so about 4 months after stopping the meglumine, are exceedingly high, despite a normal renal function. And Matt is still somewhat ataxic and intermittently confused at the time. And in August, after about an 8-month hospital stay and I think 127 days of treatment for VL, Matt is discharged to a care home. And so just to kind of bring us up to speed as to where we are today, Matt is now 37. He's developed dense bilateral cataracts, which have rendered him blind. His ataxia and confusion have thankfully completely resolved, but he does have florid PKDL, and these are pictures of his legs. And you can imagine these are horribly painful, but he has no constitutional symptoms, and his HIV is well controlled and has been well controlled for a long time, with a CD4 count of above 200. And so the question is, you know, what do you do next? And so the Leish MDT at the Hospital of Tropical Diseases have proposed that when he does develop constitutional symptoms, to attempt to treat him with a regimen that's as least toxic as possible. And that at present is suggested to be pentamidine and miltefosine. Pentamidine because he has a low exposure to this drug compared to others, and actually worked effectively in the past, and miltefosine because it was well tolerated, and to try and protect that the pentamidine. We have discussed the use of immunomodulatory agents, particularly gamma interferon, despite Matt not having an immunodeficiency, his CD4 counts above 200, and has normal gamma interferon levels or interferon levels. So that's the end of the presentation, and I'd just like to say on behalf of all the doctors here at North Manchester, thank you so much for the team at HTD that have held our extremely shaky hand in the management of this patient, and thanks to all the lab staff as well who shared the beautiful pictures of those mastocytes that you saw there. Thanks.
Lovely. Thank you, Christina. Thank you for a very clear summary of a case that over the years has been anything but clear. And if people listening want to put any questions or discussion points in the chat, then myself and Javier and Christina will be very happy to address those afterwards. But before that, I've just got a few slides to share to develop some of the many themes that Christina has raised in her talk. So, like many VL patients in the UK, Matt acquired his infection in the Mediterranean basin, where Leishmania infantum is the dominant species, and where VL and HIV co-infection is a commonly recognised problem in IVDU in the injecting drug using population, such as Matt. I've just lost my slides, sorry. Apologies, I think something's happened and it's just booting back up again. And as it does, just to say, the other main places where visceral leishmaniasis occurs are in East Africa, India and Bangladesh, and in Brazil, where between all of those countries, 90% of cases are seen. And the other place where coexistence of visceral leishmaniasis and HTD is a real problem is East Africa. Okay, my slides have reappeared and I'm just going to present them again. So HIV infection, particularly when the CD4 count is less than 200, causes many problems in visceral leishmaniasis infection. Presentation may be atypical, treatment may need to be prolonged, and relapse is much more common. Sorry, we're having slide problems. Just wait one more moment. Okay, just confirming that you can see them now. Great. So as I said, HIV infection causes lots of problems in visceral leishmaniasis. Presentation may be atypical, as we saw in Matt, with gastrointestinal presentation being more common. He presented with diarrhea and on more than one occasion, and his biopsies from endoscopies were absolutely packed full of Leishmania amastigotes. Cutaneous manifestations are also common in HIV, both in the form of disseminated or diffuse cutaneous involvement or post-Kala-Azar dermal leishmaniasis or PKDL. PKDL classically follows successful visceral leishmaniasis treatment or occurs towards the end of treatment and takes the form, as you can see in this picture here, of maculopapular or, as you can see here, nodular rash. It occurs more commonly in Donovani, which occurs in East Africa and India, compared to infantum, and in Donovani it occurs more commonly in Africa than it does in India. But it is increased in frequency in people living with HIV, as in our case. And importantly, it can also present as an iris phenomenon. And as Christina said, this patient started off with a CD4 count of 30, now has had very good immune reconstitution. So quite a typical presentation of PKDL in an HIV infected patient. It's also harder to treat, and as again Christina alluded to, requires prolonged courses of treatment. So I'm sorry, I'm just trying to move my slide on. So there are only 5 classes of drugs available for treating VL. Firstly, ambisome, which we're all fairly comfortable with using, which is well tolerated, has well characterized side effects. Secondly, miltefosine, which is attractive because it's an oral option, has a very long half-life, so it can't be used for prophylaxis, but can be poorly tolerated with significant GI side effects, particularly vomiting, and also has to be used with care in the elderly who can suffer much more from side effects. Birth control needs to be thought about in women of childbearing age because it has also problems of teratogenicity. Then meglumine, which replaces sodium stibogluconate, which is no longer manufactured, but is closely related drug, causes lots of predictable and dose-dependent and cumulative toxicities. It causes QT prolongation. It causes myalgia, particularly in those in larger people with more muscle bulk, and it causes hepatitis. Then we move on to paromomycin, and paromomycin's anti-leishmanial activity was first discovered by accident by MSF, who are treating outbreaks of dysentery in East Africa in VL infected patients, and it's now commonly used in East Africa in combination with meglumine as a treatment shortening agent. It's an aminoglycoside, so it has the side effects that you would expect, and it's not available in the UK, as Christina alluded to. It has to be imported on a named patient basis via the WHO. And then finally, pentamidine is very useful as a prophylactic agent. It's our first line prophylactic agent, but when used on a daily basis, has significant side effects, including pancreatitis, including permanent diabetes and hepatitis. So that tends not to be used for treatment courses, apart from in desperate cases such as the one that you've heard about. And so, in terms of choosing which treatment to use, particularly in patients who have relapsed and who've had prior drug treatment, the glib and easy to say but difficult to do advice is get it right first time. The patient and the drug has to be selected very carefully based on prior exposure to previous anti-leishmanial agents, prior response. There were some drugs that we knew Matt still had some response to, but some which he'd completely lost response to, toxicities and how that patient might cope with those toxicities. And as I mentioned before, the toxicities are always cumulative. Added to that, the different drugs are more effective for leishmaniasis in differing amounts depending on where the leishmaniasis is acquired from. So stibogluconate resistance was first described in India, and ambisome is the first-line treatment there, where leishmaniasis remains highly sensitive. Miltefosine is also effective there, but in East Africa, stibogluconate and paromomycin are usually first-line. Obviously, these patients tend to be very unwell. They tend to be immunosuppressed from the leishmaniasis if they're not already immunosuppressed from other causes. It's important to look for and treat intercurrent infection, including bacterial, and also think about sending beta-2-glucan, galactomannan, screening for fungal infection. And of course, in these very cachectic patients, think also about nutrition. So treating leishmaniasis in HIV infection is much harder, the prognosis is worse, and initial response rates are lower. So longer and combination treatment courses are needed, and toxicities as a result tend to be worse. We also know that patients with HIV infection have a very high risk of relapse, approximating 100% in trials in East Africa if the CD4 count is less than 200, and even with a higher CD4 count are also at risk of relapse. And as is the case in this patient, antiretroviral therapy and establishing immune reconstitution is key to treatment. So once you've finished a course of treatment, then as you've heard already, watch out for relapse, make patients aware of the symptoms to look out for, and in a selected group of patients, so those who are highly immunocompromised and those who we know are at high risk of relapse, we undertake monthly PCR of the blood in order to pick up relapse quicker. Just to say, importantly, that is not a test for diagnosis, where splenic aspirate and bone marrow aspirate remain much more sensitive. Secondary prophylaxis I've touched on already. Current guidance, including the American Society, is to give HIV, people living with HIV and with CD4 counts less than 200, prophylaxis, secondary prophylaxis immediately after their first course of treatment, but all other patients to only give prophylaxis once they have relapsed already. Having said that, there's evidence that certain groups, for example, bone marrow transplant patients, have a very high risk of relapse, and so individual practice may differ, and obviously a lot of these decisions are made on a patient-by-patient basis. First-line treatment, first-line prophylaxis is 3-weekly IV pentamidine. We would never give miltefosine because of its long half-life, and we would tend not to use the other agents first line because we would tend to try to reserve those for treatment for when it's needed, for if it's needed next. So in summary, gastrointestinal and cutaneous presentations are much more common in immunocompromised patients with visceral leishmaniasis, including those with HIV infection. And in this group, prolonged and combination treatment might be necessary. It needs to be individualized, and toxicities need to be looked out for carefully. Give prophylaxis to people living with HIV with a CD4 count of less than 200, and treatment with antiretrovirals are key to treatment success. I'd just like to end by thanking Adam Gray, who has set up this MDT and put a huge amount of work into its running. to Steve Walker, our dermatologist, Peter Chiodini, outgoing parasitologist, but will always be a leishmaniac, Laura Nabarro, incoming parasitologist, Johnny Evans and Claire Worrell, who have done sterling work as parasitology registrars, Jonathan Joseph, ENT surgeon, and Diana Lockwood, who has handed over care of leishmaniasis patients at HTD to myself and to Steve Walker. And lastly, to say thank you to everybody who has already dialed in and presented cases. It's great fun discussing and managing these cases between us. We're often operating, certainly in the VL patients, in an evidence-free or a very evidence-sparse zone, and it's very nice to have these discussions between us. Please do send us an email and drop in and join us for one of our MDTs. Thank you very much. But I just wonder, whilst people are thinking about questions, whether Javier, who has scratched his head many times with me about what to do with this man, whether Javier has any further comments, in particular in terms of where you're going now with this man who has florid PKDL but is otherwise well, and who has now a good CD4 count. So although he has highly resistant leishmaniasis, of course his outlook has improved compared to when he had such severe immunosuppression when he first met him. So Javi, any thoughts from you?
Gosh, where do I start? I mean, we thought this was the end, basically, when he failed therapy and he was completely toxic with an encephalopathy. We felt that he was going to die. We moved him under the care of the dying into a nursing home. And then I went to visit him into the nursing home as a courtesy and found him looking fantastic. And then is when we brought him back to the group, because pretty much we felt there was nothing else to be done. And I really don't understand what happened, because all the constitutional symptoms are gone and he just got the skin reactions. And another thing interesting is that he really, with us, he never had a low CD4 count. In 5 years, he had no CD4 count, and 4 years on, he appeared to develop the post-Leishmania syndrome. So it is rather unusual. And as what to do now? Well, he is a warrior. Matt wants to continue with therapy, and he wants to do anything we can to help him. Although right now what we're trying to do is try to correct his cataracts to get his vision back, and then he would be able to live independently, which is really very much needing that. But I don't know, but you will hear from me, I'm sure, more in the future.
Thank you, and we'll be delighted to hear from you again. So a few questions coming up in the chat now. So for the Manchester team, just some questions around Matt's HIV infection. Christine, if you can just summarise his current CD4 count and viral load and his current antiretroviral regimen, and also a question as to whether he's had an immunological workup, which he has. And again, I will let the Manchester team talk about that. And then after that, I'm going to ask Peter Chiodini a question about drug resistance, and Steve Walker a question about PKDL and steroid treatment. But first of all, Christina and Javier, how's Matt's HIV and immunodeficiency workup?
Okay, so the HIV has been practically undetectable all of the time, except he came to us on dolutegravir, lamivudine, and abacavir, and he developed resistance to that with a mutation of lamivudine, and he was switched to a darunavir-containing regime, and he's been undetectable ever since. His CD4 has, percentage-wise, has always been in excess of 50%, so 50, so really very high. And when he has had neutropenias and bone marrow problems, that has dropped on absolute numbers, but at the moment is running in excess of 350. So it's really good, and he's been undetectable now for a significant period of time, except the one blip. The immunological workup, we sent it to the group in Cambridge, who looked at all different aspects of interferon production and other cytokines, IL-2, and well, the full workup, and it was really nothing in there that we felt it could be corrected. It was completely normal. So it was puzzling that it didn't seem to have any immunodeficiencies that we could detect on looking at the whole T cell and cytokines, and his CD4 was actually quite good. So I think it just appears to have a huge burden of parasites to start off with that we have never really controlled with all the treatment that was given, and perhaps it was problems with initial selection. He has had treatment now for such a long time. So yeah, that's about it with the controls and the immunological.
Great, thank you. Lovely, thank you, Javi. Yes, we looked very hard, didn't we? We wanted to find a gamma interferon deficit to justify us giving him gamma interferon, and we failed to do that. Everything was normal. Great. So the next question was, what evidence is there concerning acquired drug resistance? I'm going to let Peter Chiodini comment on that from a lab perspective, but just to say that it's very hard to culture Leishmania amastoides. We had hoped that we would be able to test using our colleague Vanessa Yardley's laboratory at the London School of Hygiene and Tropical Medicine, but unfortunately none, despite the abundance of amastogotes, none of them have grown, so we were unable to do that. And certainly extrapolating from in vitro test results to in vivo responses is very tricky and is not always reliable. Peter, do you have anything to add?
Thanks, Anna. Can you hear me okay? Okay, yeah. I mean, when bacteriologists talk to me about drug resistance and I say we don't even have MICs to these organisms, they look astonished, but you're dealing with eukaryotic cells that themselves live in eukaryotic cells. That's problem one. Problem two is that if you try and culture them, only about 50% at best will grow in the best of labs. You then have the problem of how you're going to do it. So let's take stibogluconate, the pentavalent antimonials. They have to be metabolized from the pentavalent to the trivalent to act. And in the mammalian cells, there are influx pumps, efflux pumps, and also conjugation to organisms to other molecules that can inactivate the drug. So how do you do the in vitro testing? You can do it with promastigotes, which is what they grow up in culture, but they're extracellular. They're meant to be in an insect. They don't always correlate with the amastogotes in the macrophages. Macrophage cultures are really difficult to do. And in the old days when they had DNDi money, Vanessa and Simon Croft at the school used to be able to do that, but not possible now. What about markers? There are very few validated markers that we can test for. We need whole genome sequencing to do it. The other point is these parasites are capable of considerable aneuploidy, so they can rapidly ramp up their genetic material quickly and then lose it in culture. So you're kind of chasing a moving target. What's happening in the host may not be happening in the test tube. What horrifies me is that the Leishmania community is learning the lessons we learned years ago with malaria, in that combination therapy from the beginning is what we are going to have to do. They can get resistant to combinations, certainly, and more easily to a combination that's got peromomycin in it. So really, for the future, especially in resource-rich environments, we need to be thinking about combination therapy earlier rather than later in patients like this. One of my points as to why this chap's doing so badly is effectively he's got resistant parasites, and even if he didn't have HIV and if he had a fully competent immune system, he'd still be in difficulty because he's probably had drug-resistant parasites for some time. And the fact that he's immunocompromised, plus he's had sort of intermittent treatment, is all a recipe for the current situation. Not a happy background, I'm afraid, but I think that's where we are at the moment. Thank you.
And very quick add-on, Peter, from Dave Moore, sequencing and genomic markers of resistance.
Yeah, we can do, you'd have to do whole genome sequencing, which is what we do with malaria, and also you have to validate the markers. So you can screen for the known markers, but that doesn't mean to say there's not another marker that you haven't found. So totally agree with you, Dave. It's what we do in malaria, whole genome sequencing, and look for the markers, then validate them. We need to do the same for Leishmania. The trouble is validating them. It's much more difficult to grow these parasites than it is to grow malaria parasites, where culture is relatively straightforward and we have a reasonable stab at sort of MICs. But that's where we're going. And I think as sequencing gets quicker and quicker and easier, that's how we'll have to go.
And so final last question, thank you, Peter, before we move on to Steve's talk, and I'll ask Steve and Peter to answer this, and I'll answer it myself as well. Is there scope for getting a better evidence base? What are the trials that we would like to see? I'd like to see some trials of combination therapy and potentially combination therapy of shorter regimens. Steve and then Peter.
Thanks.
Okay, I think in the interest of time, we are going to move on, and Steve and Peter can both pop in the chat their answers to that question. Sorry about the technical problems. I've had to move from one computer to another as well in the last 10 minutes. So thank you for really interesting discussion. We'll try and answer all of the remaining unanswered questions in the chat, but for now we'll move on to Steve, who is going to talk about American cutaneous leishmaniasis 3 ways.
Okay, well, I'm going to do American cutaneous leishmaniasis, and it's 3 ways because we've used 3 different treatments. And it's a way of discussing the treatments for American cutaneous leishmaniasis, and hopefully discuss some of the diagnostics as we go along, and some of the reasons for the choices that were made and we currently make, and that we sometimes discuss in the MDT. So the first gentleman is a 21-year-old man who'd been in Belize, and he presented with this ulcerated lesion on the antihelix of the ear, but also on general skin examination had a nodular ulceration on the left lower back. As I say, he'd been to Belize. Can I have the next slide, please, Adam? And a skin biopsy was performed, and thank you to Dr. Peter Ellery, our consultant histopathologist, for these lovely images of granulomatous inflammation. And I think we'll move on because I can't indicate the granulomas from this end. Thank you. Now, I think what's the first thing to comment on is that at the time that he had his skin biopsy, he was a fresh specimen was also sent for Leishmania studies, which are microscopy, culture, and PCR assays for Leishmania DNA. And you can see on the left-hand slide, there's a PCR which looks for Leishmania DNA, a common assay for all Leishmania species, and nested within that is the PCR assay for American species. As you can see, that his the patient's assays were co-localized to the one of the positive Viarnia control, confirming that he's got Leishmania Viarnia. And that's one of the reasons why it's important to give a good travel history when you send the specimens to our laboratory, because the PCR that's used will be determined by the travel history of the patients. It's slightly more difficult if you've done the biopsy and then you feel that it might be Leishmania to do it on fixed tissue, but that is possible to do with curls taken from the histopathology block. So it's not always necessary for patients to have a further biopsy, but sometimes we do have to do that if the PCR on fixed tissue is not positive and we still suspect Leishmania. Can the next slide, please, Adam? So he was diagnosed with cutaneous leishmaniasis secondary to Viarnia, and so he was treated with intravenous sodium stibogluconate 20 milligrams per kilogram on a daily basis for 21 consecutive days. And just to point, Anna highlighted that sodium stibogluconate is no longer available, but that's in the UK because GlaxoSmithKline stopped making it. However, it is still available in India, where it is manufactured, and so you can get it in many other parts of the world, but not in the UK. And so subsequent to that, we've had to switch to using meglumine antimoniate, which you've heard about. And so this treatment is admitted as an outpatient through our OPAT service, which is based in the clinic. And you can see another one of our patients receiving the treatment. And 40 days after completion of the 21-day course of sodium stibogluconate, he was still left with a small erosion in the pinna, but it was much shallower and less marked, and the back lesion had completely healed. And so again, another message from this case is the fact that you won't always see complete resolution. And in fact, in the majority of patients, you won't see complete resolution of the skin lesions during the treatment period, and that goes for all of these treatments, not just pentavalent antimonials. Could I have the next slide, please, Adam? So case 2 is a 70-year-old man who'd been in Bolivia, and he was a keen bird watcher, and his main goal in life was to pictorially document all the birds of Bolivia. And so this took him to many rural places, and obviously places where he's likely to encounter sandflies. And he presented with this raised and ulcerated plaque on the anterior abdominal wall. He also had smaller lesions on the right upper quadrant and also on the right thigh. But what was typical, or what was marked by, which is not demonstrated in the picture, is that when you examine the skin around the large ulceration near the umbilicus, there's actually a marked subcutaneous linear infiltration extending towards the umbilicus, so sort of a lymphangitis associated with this. And that's why it's very important not only to look at skin lesions, but also to feel them and to feel around them. And so he also underwent a skin biopsy. We have a next slide, please, Anne, which confirmed this granulomatous inflammation. A mastocytosis was seen on both smear and on the histology, and he again had a PCR positive result confirming Leishmania biarnia, which is unsurprising from Bolivia. So we wanted to give him oral multiphysin, but at that time stocks were very low in Europe, and we didn't have any available to us. So I was forced to use intravenous liposomal amphotericin, and following fairly standard guidelines now from the IDSA, we used a dose of 3 milligrams per kilogram per day for 5 consecutive days, followed by a further dose 5 days later. However, at day 4, he was noted to have some renal impairment, and so we interrupted treatment until that had improved back to his baseline renal function. Can I have the next slide, please, Adam? And so 5 days after his 6th dose of ambisome, he had completely re-epithelialized his lesion, and the induration had settled. Thank you. Next slide, please, Adam. So the third case, another younger man in his 20s who presented with this raised ulcerated plaque over the anatomical snuff box. Can I have a next slide, please, Adam? And he had a skin biopsy, which again confirmed Leishmaniasis with granulomatous histology and a mastocytosis. But his PCR confirmed Leishmania mexicana. He too had been in Belize, and so again, travel history is important, but it also demonstrates the importance of the PCR assay in delineating these different species. And because he had Leishmania mexicana, I elected to treat him with intralesional sodium stibogluconate. And so you can see me here injecting this lesion with, and it's slightly different now with megalamine, because with sodium stibogluconate, you'll remember that that was a multi treatment vial in a large brown bottle, and so you used to take the sodium stibogluconate out using a filter, whereas megalamine comes in single 5 milliliter ampules. And you can see me here infiltrating around the edge of the ulceration, and usually going at different 4 or 5 different points, and also attempting to ensure that the infiltration also gets into the base of the lesion as well. Go to the next slide, please. So we do this weekly, which is obviously a bit slightly onerous for individuals who have to travel any distance, but you can see that after 3 treatments, I'm sorry, it says 4, after 3 treatments, the ulcer looked like this. So it's much shallower. The raised edges had flattened off. It was virtually, really on its way to re-epithelializing. So because he traveled to see us on the 4th week, we gave a further treatment. So this was after 3 treatments, not 4. And he did very well and resumed his work overseas afterwards. Go next slide, please, Adam. So with Leishmaniasis, we talked about the transmission, and we talked about the range of clinical manifestations of this and how immunosuppression can really influence those. And that's particularly so in the cutaneous leishmaniasis that I see, that in immunosuppressed individuals tend to be far more cautious. None of the individuals who presented today had any immunological impairment and all HIV negative. The next slide, please. So the distribution of cutaneous leishmaniasis causing organisms is wide, and the one thing that we always try and impress upon people is the fact that it's endemic around the Mediterranean littoral. So, for example, seeing cases, particularly from Spain, is very common in the Alicante region of Spain. Is very common in our practice, but also, in Italy, we've seen also patients from Greece and other parts of the Balkans. Next slide, please, Anne. Quality of life is also a major problem that's an emerging factor in the leishmaniasis literature globally, and certainly travellers to the UK are no exception. And in one of our quality improvement exercises, we identified that people with cutaneous leishmaniasis returning to the UK have a moderate impact on their quality of life as measured with the Dermatology Life Quality Index. And that's the same as people in endemic settings and their impact on their quality of life. And that's really interesting because we like to think that people have access to treatment here, the access to all the range of treatments possible, and yet the disease has a negative impact on people's quality of life. And so it's important to bear that out, and I think we really need to continue doing work around this area and the psychosocial burden of the disease, certainly globally, but also to look at assessing longer term outcomes for cutaneous leishmaniasis, particularly with respect to scarring, disfigurement and stigmatization that scars can cause. Next slide, please, Adam. So it's always the great question, systemic versus local treatment, and this has been a really difficult question to answer because a lot of the data that people rely on is retrospective and without controls. Diana was involved in an important piece of work with the Leishman Group, which we are still part of, which is European Consortium of Leishmania Treating Centres, to actually look at the literature around who we should treat and why. Well, the rationale for treating certain individuals with systemic therapy is to minimise the risk of mucosal spread of the disease from the cutaneous lesions to the mucosal surfaces of the nasopharynx. And the risk factors identified were acquisition of the disease in Bolivia, having multiple lesions in the upper part of the body, and larger lesions or lesions with a longer duration of not being treated, which is a very common factor for travellers or returning travellers, because obviously it's not always on people's differential list initially until they actually get a biopsy, and immunosuppression as well. Can the next slide, please? So for those patients with the Viarnia subgenus, we would advise them to have systemic therapy, and systemic therapy with pentavalent antimonials, and as we've demonstrated, we give that on an outpatient basis, and with good patient selection, avoiding those with particularly with cardiac comorbidities and advanced age, it's safe and well tolerated. Although, as Anna alluded to, myositis or myalgia and arthralgia are common later adverse effects that most people will experience to some degree. Hyperamylasemia is also well recognised, but actually is hardly ever a cause for stopping the drug, and certainly we tend not to do it unless there's concomitant abdominal symptoms such as pain. Can the next slide, please? I talked about oral multefosine. I think the renal impairment here is overstated in terms of cutaneous disease, but certainly in endemic settings with multefosine, with visceral leishmaniasis, you can get a lot more renal impairment. Those patients tend to be much sicker and more debilitated. But the teratogenicity is a big problem, because obviously if you're treating a female patient who's got childbearing potential, discussing the fact that there's going to have to be prolonged contraceptive needs for 5 months and possibly more after taking the course of miltefosine may limit that use in certain individuals. There's sort of post-trial experience with pregnancies and miltefosine, and to my knowledge to date, there's not been an adverse fetal outcome. However, that needs to be borne in mind if you're wanting to prescribe miltefosine to a woman. Thank you, Adam. So, liposomal amphotericin. Now, you're familiar with using liposomal amphotericin far more than with miltefosine and pentavalent antimonials. And it is a good drug for cutaneous leishmaniasis. However, it's not as good as one's initial gut reaction would feel it to be. And certainly there's data from the French group who are part of the Leishman consortium to suggest that in American cutaneous leishmaniasis that the response rate is no better than a lot of the other drugs, and actually maybe slightly worse. And there may be some issues around penetration into the skin. I've also used it in mucosal disease and feel it's a lot better for mucosal disease than for purely cutaneous disease. And you'll be aware of the adverse effects, and we're happy to share our outpatient guideline for leishmaniasis if anyone needs it. Okay, next slide please, Anne. So the summary, I suppose, is that there are 3 cases of cutaneous leishmaniasis, each receiving a different treatment regimen. And the treatment conditions really are, which species is it, which is why PCR is so important, and particularly so in people who've had multiple potential places of exposure, so backpackers, military service personnel, etc. And then the number of lesions and particularly the sites, and whether it's adjacent to a facial structure as such. Okay, so we talked about the need for less toxic drugs, and I've talked about that scarring can cause long-term psychological morbidity. Thank you very much.
Lovely, thank you, Steve. Thank you for persevering despite all of the technical problems. So we are almost out of time. I'm just going to very quickly come to a sort of combination of questions which came up early on in Steve's talk. I think the last question on choice of risk of mucosal disease has been covered subsequently. But I just wonder whether Peter Chiodini might like to talk very, very briefly for 30 seconds on speciation, how it's done currently in the lab, and how it can also be done. Other methods as well.
Right, species identification. We use a nested PCR, round 1, round 2, and round 2 by molecular size. We sometimes need RFLP to sort it, and ultimately can go to sequencing. We will move probably within the next year or so to HSP70 real-time PCR and sequence the product. The take-home message, as you allude, is that without the definitive species identification, you can't properly manage the therapy, and particularly with those that are prone to give mucosal disease, it's obligatory to get down the species. So watch this space. At the moment, it's nested PCR, molecular size and sequence when we need to. For the future, real-time PCR, then sequence.
Fantastic, brilliant. Thank you, Peter. So that just leaves me to say thank you to all the speakers. Thanks especially to our guest speakers, Christina and Javier from North Manchester General. And thank you for some really interesting cases. Do send us your cases. We're very happy to discuss. We'd love you to join us at our monthly MDT meeting. And that just leaves me to say that next month, June the 23rd, 6 till 7 p.m, please register to get the new link. It's a different link to this one. Tommy Rampling and guests will be speaking about emerging arboviruses, what's new here in the UK and what's new at Ripple. So thank you very much for joining us, and good evening.